Today we are pleased to have Dr. David Perlman joining us for a discussion on Conceptualizing Care Continua. Dr. Perlman is a professor of medicine and the Associate Chief of Infectious Diseases at Mount Sinai Beth Israel. He received his medical degree from Albert Einstein College of Medicine, after which he pursued residency in internal medicine at New York Presbyterian Hospital. He returned to Einstein to complete his fellowship in infectious disease. Dr. Perlman's clinical interests include the HIV and HCV in patients who have a history of substance abuse. He is the director of the Infectious Disease Core of the NIDA-funded Multi-Institutional P30 Center for Drug Use and HIV Research, where his role is to facilitate multidisciplinary interactions and research among biomedical and socio-behavioral scientists. Please join me in welcoming Dr. Perlman.
Thank you, and thank you. It's an honor and pleasure to be here, and a pleasure to get to tell you about some of the things I've been working on and thinking about over the last year or so. And it's also a welcome opportunity to share work as part of our expanded Mount Sinai system, so we can all get to know the different things we all do and find ways for them to synergize and do more work. While my work is in infectious disease, and most of the examples I'm going to give you are in ID, I think a bunch of the points and principles apply to any field in medicine where care is delivered in sequential steps, as most of it is. And so I encourage you to, as I talk about things, if you're not an ID person, to think how might this apply to your own respective fields. Because I think it really, this concept of thinking of care as a care continuum of a series of steps that we can measure and define and monitor is a very useful and applicable one, although one that can be made a little bit better from the models that have been used thus far. I have no disclosures other than this was supported by a number of different NIH grants. So the construct of care continua sort of became very prominent in the field of HIV, and then was given official sanction during past President Obama's presidency, when through an executive order, he made a HIV care continuum initiative that directed the CDC and the Public Health Service to look at things in certain ways. And the concept also is implicit in some of the World Health Organization approaches to HIV, where they express things as their 90-90-90 goals, in which the WHO official goal is that 90% of people be diagnosed, 90% of people initiate treatment, and 90% of people achieve a sustained virologic response to, or virologic suppression to antiretroviral therapy. One side point I can't help but mention, which is that 90-90 goals sounds good because we think of 90 as a good grade. But these are sequential steps. And so if 90% of people do the first step, and 90 do the second step, and 90 do the third step of any sequential steps of care, that means 73% of people have gotten through. That's the goal. So the WHO goal for HIV care is that 73% of people be virologically suppressed and that 27% not be. So international goals are often lower than US goals, and that's just something we should realize. But these models of care continuum have caught on like wildfire, and people are very enthusiastic about them and describe them as an effective tool for improving the health of people living with HIV and for achieving the public health benefits of antiretroviral therapy, and is an important tool for measuring the performance of HIV care and treatment programs. And in fact, a number of these steps in the care continuum are part of state metrics for HIV care that IAM has to follow and that states report on. But while they're increasingly applied in a number of other domains, both hepatitis C, number of non-infectious conditions, for some of those who have been around a while, when this first sort of started to be discussed as the HIV cascade or continuum of care, some of it said it was an old thing with a new name. Early in my career, I did a lot of work in tuberculosis back in the late 80s, early 90s, when New York and the US had a big TB epidemic. And by that time, we had really good drugs for TB. And the outcomes were really bad, not because there weren't highly efficacious pharmacotherapy agents, but because of all sorts of other things in their effective delivery or implementation that became barriers to achieving the optimal goals that one might think one should be able to get in an efficacy study, because the drugs are efficacious in idealized circumstances, and I'll return to that. And in TB, when I was doing this, and really still, there's a lot of interest in what was then called operational research. That is, how the things we know to be highly efficacious actually get delivered and operationalized. So what are care continua? They're visual descriptions of selected quantitative data. And in doing this, the form impacts the content and the message, and I'll show you some things about that. But it affords a particularly useful way to focus on effectiveness and implementation processes, and I'll define that in a minute. And then you can look at the steps of care and see where there are gaps. Are a certain proportion not diagnosed? Does a certain portion not get engaged in care? Do they not receive the right evaluations? Do they not receive the right treatments? Do they not complete the right treatments? And you can depict these as a series of bar graphs. And these have caught on, I think, because they look very clear and intuitive. They sort of have face validity. They become very useful for people to present data to policymakers. And I think that's part of why it became incorporated in official evaluations of HIV care, because they do sort of have this intuitive appeal and ability to express things to policymakers. But they're also very good public health measures of selected outcomes. So what I'd like to do today is discuss what these care continua are, how we sort of pick what the steps should be in a care continuum model, the importance of defining each step carefully, the importance of defining them in consistent, clearly defined ways so that studies then are comparable, and the importance of using these in conjunction with some public health or theories of behavior change or clinical outcomes, so that when we see a gap in a step, we can then think of why those gaps might occur. And then I want to point out some of the advantages of the existing models and some of what they don't depict, and that these models then could be improved by finding ways to add these other parameters, in that they typically don't depict incidence or mortality, and how we should analyze progress through them is still sort of an open question. So if we go back, what seems like ancient history, but 30 years ago or so, to work in TB or STIs, people really used what care continuum models. They didn't call them that. There was the PO model for tuberculosis and then the PO-Franson model for STIs. And I love the way PO described these. He described these models as the formulation of a simplified model to represent it wherein a series of interlocked subsystems are expressed quantitatively by a limited number of epidemiological, sociological, administrative, operational, and technical parameters. So the intent was to have these models be multidisciplinary and look at multi-level factors. And that the object of the systems analysis is to determine which of the parameters can be expected to exert the greatest influence over the total efficiency of the system in a given situation, so as to guide planning, the implementation of services, and to forecast the efficiency against which the observed performance can be measured. Funny phrasing, but really sort of clear, and makes it clear the intent is to look at multi-level, multidisciplinary factors that influence clinical outcomes on a public health level. And so they applied this to TB, and they applied it to STIs, and there are a number of commonalities to most of these models. So for TB, they constructed their care continuum to have the following steps, and these are applied in low and middle income, predominantly low income countries, where access to care is a significant barrier. So they made a first step. Do patients with TB, do they have TB? They may or may not have symptoms. Do they then seek medical assistance? Do they live in an area, in fact, where they can get medical care, and that not being the case for everyone? Other than appropriately diagnosed, are they offered the right treatment? Do they engage in the right treatment? Do they adhere to the right treatment? Do they complete the right treatment? And for STIs, their model was interesting in that it included an aspect of prevention, which I think is critical, and calling them care continuum sort of obscures the need to address that. So in those models, they said, does the person have an STD or STI? Are they symptomatic? Did they seek treatment? Did they go to a health unit? Were they treated correctly? Were they adherent? Were they treated effectively? And were their partners treated? And I just want to show you this, the P.O. Franson STI model. Most of them now we put the proportion of something on the y-axis and the sequential steps on the x-axis, but that's arbitrary. They happen to array it the other way. But in this community, they started with all women. And they said, what proportion of them has an STD? Or are they symptomatic? Do they seek treatment? And you see the decreasing proportions. And so you see where people with STDs are lost, at which step. And again, they included at the bottom, if someone has STIs, their partner should be treated. And so they included that aspect of prevention in the model. And then by looking at the model on the top, they saw where they had lots of losses. And they were able to model out in a visual sort of way what would happen if we changed our delivery system. So if instead of treating only those people diagnosed in a particular way, what if we did syndromic treatment, treating everyone who shows up? Well, ultimately, a greater proportion would get treated. Or what if we just did community level treatment and not even attempt to make a specific diagnosis? Well, then an even greater proportion would be treated. So these models can help you think about where there are losses and where you could change your delivery systems to get different outcomes. One important thing in depicting these as bar graphs is keeping track of what your numerators and denominators are. If you take the numerator of your first bar to become the denominator of your next bar, you visually de-emphasize the losses you see. And you can have your last bar graph look like a good percent, and visually, quickly, people think, oh, we get pretty good outcomes. Whereas if you really show that this losses are cumulative, it makes clearer the adverse impact of many of our processes in getting people through the steps of care. And I'll show you a picture of that in a second. With respect to HIV, this is clearly the setting in which these models have been most fully developed and most consistently applied. They first were applied to looking at outcomes of maternal to child transmission of HIV and then to HIV generally. And the CDC now has two formally well-defined HIV care continuum approaches they use. They both use the same 5 steps, but with different denominators. The first model they call the diagnosis-based HIV care continuum, and that model is looking at the population of people who have been diagnosed. And that's a measurable number, so that doesn't require estimation. And then you do also want to know, what about the undiagnosed people? So there's a separate model that uses the denominator, everyone infected, which is something that needs to be estimated. And then because of the way the models are built, they're useful to different degrees in looking at different subpopulations. So this is a prevalence-based HIV care continuum. And it's a little old, but the point is to look at the steps. So they look at the proportion who have been diagnosed, estimating the proportion who have not been diagnosed. Then of those who are diagnosed, they look at the proportion linked to care. Now they do this in a different color because linked to care is something that happens at different points in time for different people. So to make this a standardized, measurable thing, you need a time frame to attach to that. So they will often say linked to care within 6 months or linked to care within 12 months. And so that isn't necessarily the same denominator as all those diagnosed, because they may have been diagnosed, we don't know exactly when, or it was many years ago, it may not apply here. So they depict this in a different color because it's not exactly comparable. And then are they engaged in care? And we'll talk about what that means, because that can mean different things of different significance. Were they prescribed antiretroviral therapy, which can be measured in different ways? And do they achieve virologic suppression, which historically has been measured in different ways as our tests have changed. And then there's the diagnosis-based HIV care continuum, which is similar, but looks at those linked to care among those diagnosed within a certain time frame and linked within a certain time frame. Again, are they retained, prescribed, or virologically suppressed? So these are the standard care continuum visual depictions that CDC constructs for states, for counties, and for the nation. This is New York City, one slide from the City Department of Health. And I just want to show here these percents. Well, it looks like, your final outcome, 76%. That's within the WHO goals, except that this is 76% of the prior bar. And overall, back in this year, I can't read which year this is from, overall, only 39% of people with HIV in the US, in New York City, were virologically suppressed. So the cumulative effect of all these losses is really quite dramatic. And so for this reason, it's not just that we need good drugs, because our antiretroviral drugs work really well if people are given them and take them. But even there, we know the drugs to be more than 76% efficacious. But all these other steps limit the population level benefit from highly efficacious drugs. So in order to use these care continuum models, you want to know what steps of care do you care about. And these should not only reflect the logical flow of care, but you'd like the steps to have predictive value. And there's been work done with HIV in particular to look at which definitions of each step are predictive of different downstream outcomes, including, in some cases, mortality. Testing can mean a bunch of different things. So for many care continuum models you could envision, the first step may be, does someone have the condition? So in HIV, that's a pretty dichotomous outcome. They can be HIV tested, yes, no. For something like Hep C, where our diagnostic steps are a little more fragmented, it's a different thing, because readily available to many health departments are, did people get antibody tested? And as you know, then many people who are antibody tested in certain settings have to go somewhere else to get a viral load to know if they actually have active infection. So the diagnostic screen, or test step sometimes has internal dimensions, which means it can be fragmented and you can be lost even in the diagnosis step. For other conditions, that screening thing may be, a screener for substance misuse disorder, or substance use disorder. So it may not be a biomarker. It may be some other measure. Do they have this condition? It may be some test. Do they have diabetes? And then not only are there different tests, but there are different ways those tests can be implemented. They can be an opt-in test. You have to approach someone for consent for HIV testing in a number of settings. In some cases, it can be done automatically as an opt-out. And those impact the proportion get done. So the proportion who are tested reflects things about the test, and it reflects things about how the test is implemented. Part of what set me thinking about care continuum models in more detail was being involved in two studies. One of them, I'm working with some colleagues on a series of systematic reviews and meta-analyses of hepatitis C epidemiology and care. And in doing a systematic review of the hepatitis C care continuum, and in writing the protocol manuscript of the protocol for doing so, we had to predefine what we would consider the steps of the Hep C care continuum. Now, there's no standardized Hep C care continuum as there is for HIV through the CDC. There are a bunch of different papers that express it in a bunch of different ways, but we had to make some a priori definitions of what we would consider the steps for them, which you pick the search terms and certain things. We also developed a study for the NIDA Clinical Trials Network, which, like the AIDS Clinical Trials Network, is a multi-center consortium run by the National Institute on Drug Abuse that looks at HIV and substance abuse co-infection issues. And this was a study to engage out-of-treatment substance users with HIV Hep C co-infection in HIV and Hep C care. And so we had to define what would be the steps of that care continuum. Now here people have two conditions. And in the settings where the study was going to be done, some did Hep C antibody testing routinely, none did viral load testing routinely, some didn't even do antibody testing routinely. So there was a little heterogeneity in the screening step. And then we had to define what the subsequent steps would be. This study is ongoing. It's now accrued and is in follow-up, and it's went through the DSMB once and they didn't close it. So all I can tell you is hasn't shown a difference yet, but we still have the power to see if there's a difference. It's an intervention study looking at a sort of slightly better than treatment as usual control versus an intervention that uses some motivational interviewing, some care facilitation or patient navigation to get people from A to B with a finite restricted number of potential sessions they could have with an interventionist to encourage them to go, certain pre-specified reminders. And so I can't tell you the outcome of the study, but we had to spend a lot of time defining what the steps of the care continuum would be, for which we would then monitor people and call them, this is a progress through the care continuum. And because it was two conditions, people both, if they have HIV and Hep C and are out of care for both, need care for both. Well, a sort of standard practice is to think that we should first engage them in HIV care. But what if a patient wanted to do it in the other order? Well, we would still consider that progress, we decided. So the Hep C steps are really sort of necessity sequential. No one's going to get treated until you know they're RNA positive. And because some people had been antibody tested, we called the first step getting an RNA test. Then the next Hep C step, getting evaluated. Now, evaluation for Hep C is something that's changed over the past decade. People previously needed a liver biopsy to assess their degree of fibrosis to decide if they needed treatment. Now we have easier measures of assessing liver fibrosis, but it also isn't clinically clear that we need to do that, though it is practically clear that we need to do that, as most insurance carriers require that in order to approve the drug, the point to which I'll return. Then whether they were given treatment, and here, if someone declines treatment, that's a different phenomenon than if they're never given treatment or they abandon treatment. Then do they complete treatment or initiate treatment, complete treatment, and do they achieve an SVR? Now the last progress between those last two steps, to some degree, is like an efficacy study. We know the drugs work quite well, and most people who complete treatment will get an SVR for Hep C. So progress between these two steps may not be as hard to accomplish as some of these other steps. And that impacts how we might statistically evaluate progress through the care continuum. But the other point is that they also need to get engaged in HIV care, initiate antiretroviral therapy, and in some cases retrieve HIV virologic suppression. This is both clinically appropriate to give them a better Hep C outcome and give them a better HIV outcome, and in some cases practically appropriate because they can't get their Hep C drugs without documenting to the carrier that this has happened. So we consider those steps in the HIV Hep C care continuum, though not chronologically, sequentially required to go in a specific order. But then there's the issue, how are we going to evaluate progress through the care continuum? Well, we can set up the outcome, the proportion who does or does not get a Hep C SVR. But one would not want to miss that the intervention moves a greater proportion of people to the right without necessarily getting them all the way to the right. So we spent a lot of time discussing this. And in multi-center trials, in doing science in a big group committee, you have a number of agendas. One is the best science, one is getting people to buy into the project and getting group consensus. So the easiest thing for us to explain and sell was that each step would get a point. And as people progress through the care continuum, each step would be given a point. Although, as I pointed out, that may not be the most clinically informative way to do that. And you can imagine weighting the steps differentially, which we did put in as a secondary measure, because how exactly to weight them would be a matter of consensus. And then we can do some fancy statistics to look at progress through the steps. So that's what we plan to do, and how to analyze progress through this care continuum. Now, one thing I want to point out is that when we find these gaps in the care continuum, that people don't get linked to care, or that they get linked to care and they fall out of care, or they get prescribed medicines and they don't take medicines, that can tell us where the problems are. It doesn't tell us what they're due to. And to think about what those gaps may be due to, you need to take these public health models of care continua, and apply some theoretic model that explains clinical outcomes or human behavior or public health system behavior. And so I want to return to this notion of efficacy versus effectiveness. If you look it up, in a Merriam-Webster dictionary, they may be synonyms, but scientifically, they've come to mean two different things. Efficacy studies, or the efficacy of an intervention, whether a drug or a behavioral intervention, or also called explanatory studies, address specifically how an intervention, a drug or behavioral intervention, works under idealized conditions. Now, this is usually what you get in a drug RCT, where aspects of study design are made specifically to increase the internal validity of that study and to isolate the impact of that intervention. Does this intervention have the outcome we're looking for under these idealized conditions? Effectiveness studies are not better or worse. They ask a different question. They ask the question, how does this intervention work under usual or real-world conditions? That is, we can show this drug works in a population of people this tall, of this weight, of these characteristics, without these other conditions. If they actually take the medicine as prescribed, for the duration prescribed, that's efficacy. But then when it's released on the market, or when we begin doing this in practice, it doesn't work quite as well, because a number of other things end up impacting it. Comorbidities can reduce the outcome you would get from a drug, and that's sometimes the reason they're excluded from RCTs, or other barriers can get in the way. And studying the effectiveness of an intervention is critically important from a public health point of view, because having the world's most efficacious drug, if it when applied doesn't give you those outcomes, is still a problem. And this is the case, again, with our TB drugs. They work great. They just, our systems for giving them to people don't work great. So these studies stress more the external validity or generalizability of an intervention. Just for completeness, there are now a series of papers talking about hybrid studies, hybrid efficacy effectiveness studies that include elements of both, where some people argue this will get us to a good answer faster. And these have ups and downs, because you sacrifice a little internal validity, get a little more external validity. Sometimes that's good, but in looking at studies, you want to ask yourself, are they efficacy or effectiveness studies? And again, asking and answering different questions. And efficacy and effectiveness play different roles in what's called the research pipeline, where they're preclinical work and epi work and qualitative work, and then we say, we think we have a molecule that may be good. And we'll say, yes, in idealized circumstances, this works really well. And then when applied, it does or doesn't work really well. Those are effectiveness studies. Implementation is a little, they put it after, although really it's studying how the systems you use to translate efficacy to effectiveness in healthcare delivery. And then you look at the net population impact. And care continuum models look at a bunch of these things together to tell you how things are really working in these defined series of steps. Going back to what are the reasons there are gaps, you want to apply some theory of human behavior change and how things happen. And a common one that many people write into their NIH grants and look at intervention is the IMB model of behavior hinge, looking at information, motivation. And the concept here is that if people have information, they can act on it. And if they have both information about something and they have motivation to do something, they'll have the skills to change their behavior, to change some outcome. They'll know the importance of a good diet. They'll understand the consequences of a bad diet. They'll therefore have the skills to do something about it, and they'll have better outcomes with respect to their diabetes diet or their weight reduction or something. And all of this is true and useful. But it's not everything. And it's a very incomplete way because it only looks at selected individual level factors. So I just want to define another couple of terms. There are different levels of influence that influence outcomes. Individual levels, which are anything where the unit of measurement is that individual, whether it's that individual's knowledge on a knowledge assessment scale, or whether that's that individual's genetic marker, or their sociodemographic characteristics, or their perceptions, or their own prior experiences. These are individual level factors, and there are a whole bunch of them for different conditions that are known to be relevant and others that can be explored. Then there are a number of super-individual factors, that is, factors where the unit of measurement is above the level of the individual. These can include what are called social network factors, that is, things that relate to the people you know directly or are in contact with directly. So, for example, work I do in injection drug users, it's the people do drugs with, or share needles with, or people's direct contacts. And these influence people and influence outcomes. So those are social network factors. Then there are what are called structural factors that are even above that level. They're factors that relate to the areas we live in. And there are a lot of data in a lot of settings that factors measured above the level of the individual or your own social network impact outcomes. Living in a poor area influences a lot of outcomes. Even if someone is well-to-do in a poor area, it impacts outcomes. So there are or living in an area where there are certain specific policies. If you're in a country or state where there is no syringe exchange, telling people to use clean syringes is not a particularly effective intervention if they can't get them. Whereas if they can have access to syringes through syringe exchanges or pharmacies, it impacts, they can have the motivation to use a clean syringe, but there can be policy barriers that prohibit them from doing that. And then people talk about place or area level measures. The rate of crime in this neighborhood. The rate of foreclosures in a neighborhood has now been associated with rates of depression in individuals in that neighborhood. So that's a structural level factor. And there are theories that can be applied that tell you to take into consideration these factors. Now, this is a theory I like, or not a graphic I don't love, because it's sort of all over the place. But in addition to individual level factors, and information and motivation are just two of the multiple things that can go in this part. Then there's the people in someone's household, or their social network, or their bigger social network, or the region they live in. Living in areas where there's class, racial, ethnic, or gender inequality. Policies that relate. And then other things that impact factors are where in the life course, an individual's life course, things happen. So this is one of the commonly referred to multi-level theories, ecosocial theory of Nancy Krieger, that points out if you really want to look at outcomes, there are multiple things to be measured besides that of the individual. In fact, so if you go back to the IMB model, which looked all simple and sounds good and appealing, really, if you, in an epidemiology biostat class, all those other factors are unmeasured factors or unmeasured U's, that we call them in an epigraph like this, so that in any statistical analysis, it's not just these factors that are driving that. There are a range of unmeasured factors influencing these outcomes. And when you look at outcomes without accounting for these unmeasured factors, you can get both bias assessments of intervention impact or wrong assessments of intervention impact. Okay. When you start looking at factors at multiple levels, it changes your study design and the statistical methods you need to do. Many studies will look at individual level factors as the independent or dependent variable. That's an individual level study. There are ecologic studies that will look at group outcomes and group independent variables, and those are ecologic studies. And then there are what are called multi-level or contextual studies that will look at both individual and super individual level factors, for which you need to do something called multi-level analysis to account for the fact that a lot of these characteristics at different levels, someone's income is statistically not unrelated to the income in their area. They're not the same, but they're not unrelated. So you need to do hierarchical modeling. But it can be done, and that's what I just said. I also want to talk a tiny second about terminology. And the terms we use impact how we think about things. So people used to talk about the care cascade. Well, the cascade paints you this picture of everything falling down. Now all the official documents talk about the care continuum. It's a little more affirmationally positive. It speaks to retaining people, not emphasizing the losses. More troublesome to me are a lot of the terms used to describe the interventions applied to try and fix those gaps. And people use a lot of military metaphors. We're going to target this poor marginalized population and capture them for this intervention. And it's one thing to target a molecule. It's another thing to target a marginalized group. It just, to me, is the wrong frame. And these terms evoke deep frames in our thinking. And I'm not sure our long-term public health benefit to use them. So I actually try not to use these military metaphors when applied to people. Returning to the care continuum, there's this step of testing people and identifying if they have something. And then people have to be linked to care. Now, in some places, people are tested in the place they're receiving care. They're seen in a general medical clinic and they've got a test for HIV or screen for diabetes. Their care is in that setting frequently. For other conditions, the testing may be in field sites or other places, and then people have to be referred to healthcare settings or to specialty clinics for their care. A very, very, very common barrier is that when people are passively referred from A to B, a large proportion don't get there. If you have to guess a number, a nice guess is a third get there. A third of people sent from prison for HIV care ever get to HIV care. A third of people sent from a syringe exchange with a positive PPD for an X-ray ever get there. There are a bunch of papers, something like that. It's a significant number, but the majority tend not to get from A to B with passive referral. And this is really common in many conditions. And so that's a big step in the fall off of most care continua. And for one for which there are a bunch of data I'm not going to go over that really passive referral is not a good way to get people from A to B. They need to be actively linked. They're very, very nice data that first done at Harlem Hospital. Women screened with a mammogram with an abnormality found don't get to the next step. And this was one of the first settings where they used patient navigators to get people from identified with an abnormal mammogram to a biopsy of some kind. One thing about screening is that it identifies cases of whatever you're looking at without telling you whether they're incident or prevalent cases. And from a public health point of view, you want to identify people, but you also want to know what the incidence of your condition is. And just screening people tells you they're positive. It doesn't tell you if they're an incident or prevalent case. So that information is sort of buried in most standard care continuum models. Now, actually, the WHO for TB doesn't put it in their care continuum model. They have an adjacent table next to their bar graphs to try and identify incidence in areas. But it's another critical public health factor, because how you operationalize your services will be different if the incidence is high or low. And incidence is also going to tell you something about the efficacy and effectiveness of your prevention interventions, which you'd also like to be represented in an optimal model. We clearly want to treat everyone who has a given condition in an appropriate way to an appropriate endpoint, but we'd rather do primary prevention and secondary prevention. You know, one big question in treating people who inject drugs for Hep C is, are they going to get reinfected? Well, you'd certainly like in any model looking at Hep C outcomes of people who inject drugs to track reinfection rates, and so you'd like some model that reflects that. And the current models would just identify someone as another case again, and not tell you the rates of reinfection. So for HIV, Jennifer McNary and Wafa El-Sadr proposed a HIV prevention continuum. When people are tested, and testing is the step not only to identify those who are positive, but those who are negative and need preventive interventions. You know, people can be found to have diabetes or not have diabetes, but they can be at risk of diabetes and need some preventive counseling. Or they can be HIV negative, but engaging in risk behaviors and need preventive interventions. And so if they test negative, but have relevant risks, they should be linked to prevention services. Now, I will point out, this study mentions some of the demonstrably proven prevention steps, PrEP, maternal, testing for maternal to child transmission and prevention there, condoms. It doesn't specifically mention two of the others, which are syringe exchange and opioid agonist therapy for HIV. Are they retained in prevention services? And do they adhere to those prevention services? And then are they retested at some relevant rate? But separating this prevention continuum from the care continuum, well, creating one is a good thing. You'd like to see how the factors operationally connect, because that also will tell you something. So Dennis Nash and some colleagues, I'm afraid I don't know Dr. Horn's first name, I forget, recently published an HIV model that tries to incorporate the CDC HIV care continuum, diagnosed, linked to care, retained in care, virally suppressed, with a way of looking at primary prevention. People are tested. If they're positive, they flow into this area. If they're negative and have relevant risks, they're linked to prevention services. Do they stay in prevention services? They get retested. If they're negative, your prevention services are working well. If they're positive, your prevention services failed and they're a new incident case. So this helps identify incidents among those in prevention services, but not the incidents, not complete incidents, because it doesn't quite tell you who's getting tested up here. But it's an improvement over the current model for that reason. Now, once someone gets to care is a very variable thing, as we know. And care changes over time. So for Hep C, there were lots of studies showing that liver biopsy was a big barrier to progress through the Hep C care continuum. Well, now we don't tend to do that. That barrier is gone. So that aspect of care has changed, and people progress through the Hep C care continuum a little better. There are other barriers and heterogeneity within what is saying someone was evaluated for Hep C or evaluated for depression. What exactly does that mean? Well, care is impacted by a bunch of things, and we often think of the patient-driven factors. The patient doesn't show up, the patient has competing interests, the patient's not motivated. There are other factors that influence our diagnostic workups. People show up and they may have some evaluations. Then they may, based on those evaluations, need other tests, some of which may be easy to get, some of which may require prior approval, some of which you may then need to do test A. You need their HLA-57 before you can prescribe them Triumeq. You need their fibrosis score and show at a drug screen or something before you can order their Hep C treatment. And so a diagnostic evaluation is not a one-step thing. And so people can get lost within this process of a medical evaluation. What Dr. Tritter called the stutter step. in someone's diagnostic and treatment journey, which I think is a very nice image. Then there's the issue of how we define each step. And this has been very much studied for HIV. And just as an example, I'm going to go a little quickly through some of these. What does it mean to be linked to care or retained in care? Well, for HIV, many organizations have made definitions. Unfortunately, they differ a little bit. The IOM has a set of definitions. Health and Human Services has a set of definitions. HRSA has a set of definitions. They differ a little bit. But these definitions are attempts to standardize what we call retained in care for analytic purposes. Well, these, it turns out, have different predictive value. Whether you looked at the HRSA or the DHSS definitions, whether you look at other things that include, they could be retained but have missed visits. Well, without getting into the details, people have looked at these different ones. And if you make the IOM indicator, or fail to make the IOM indicator, you get a hazard ratio of over 2 for mortality. But if you also miss clinics, there's a much higher mortality. So you can pick the definitions of your care continuum steps to have potent predictive value. And that's an important aspect of constructing these models. For health departments and for scientists doing this, then you got to think of where you get your data. What are your data sources for constructing these bars? So one of it could be, we could look at everyone in the IAM clinics, and that could be our universe, and EPIC could be our data source. Or you could be the health department and get information from all of the labs of everyone's viral load results. So there, you'll get slightly different definitions based on your data source, and you need to know that. For the CDC, in merging data from states, people move between states. They move between counties and jurisdictions. They need to account for moves and losses and deaths in order to make good aggregate data. And they recently just redid all their projections of the number of HIV-infected people by subtracting the duplicates and changed their estimates appropriately. So there are some tricky methodologic things in doing this on a macro scale. And another thing is that these bar graphs, well, they're sequential. They're not exactly time. I mean, the x-axis is usually not time. It's sequence of events. So you can make your definitions of the steps. Did this within 6 months or 12 months? But the bar graphs don't exactly mean time. And another important factor is that some papers report care continuum as cross-sectional snapshots. We did a survey, and these were the proportion of people who had progressed through at this one point in time. Or you can do longitudinal ones where you follow a whole cohort, and it is the progress of that individual cohort through the steps. You want to know that in looking at them, which it was, and different ones are useful in different settings, I'll say, and stop there. The last point I want to make, well, I guess, yes, are going to be the endpoints. In the HIV model, the named endpoint is achieving virologic suppression. Now that is an important one, but it's an important one because it's not really the endpoint. It's a surrogate endpoint that has been proven to predict morbidity and mortality. So it's a biologic surrogate measure. If someone achieves SVR for Hep C, they're cured. If someone achieves virologic suppression for HIV, they still have HIV infection. They're not cured. They need to stay on medicines. But achieving that and staying there is predictive of less morbidity and reduced mortality. But the models might be more informative, and really would be more informative, if you actually measured morbidity and mortality, as opposed to just relying on a surrogate. Oh, I guess the other point I wanted to make goes back to the point of HIV and Hep C co-infection. And there are a number of conditions that we know interact very potently. In my field, HIV, TB, treatment outcomes are impacted by whether someone's HIV co-infected. Obviously, HIV and Hep C interact. There are people who, often substance use is treated as a barrier, but it's something that needs its own treatment. So really, people who are substance using with HIV and Hep C can be expressed as being the care continuum for substance use and HIV and Hep C, and their outcomes for each of them are interdependent. And so this is someone proposed a diabetes care continuum, where a bunch of the steps are not pure diabetes things. There are other factors known to impact outcomes in people with diabetes. So these are the people with diagnosed or estimated undiagnosed diabetes. Do they have a place of care? Yes, no. Have they visited a provider in the last 2 years? Do they smoke? Now that's not purely diabetes, but it's in fact we know clearly influences diabetic outcomes. And then have they achieved glycemic control? Have they achieved blood pressure control? Not a pure diabetic outcome, but one that clearly influences the outcomes in diabetics. So, and then are their lipids controlled? And then are all of those things controlled? So as you can see, a lot of people with diabetes are not well controlled in these various factors, have not been diagnosed, and there's a fall off at a lot of the steps. So this is an application of a care continuum model looking at interacting conditions as well, impacting diabetes outcomes in the US. And returning to ID, this is another model someone constructed for HIV-TB, or actually drug-resistant HIV-TB. This is everyone with drug-resistant TB, then they're HIV tested, then have they gone through the steps of a TB care continuum? And considering all these factors can be very informative as to where the gaps are. And then if you apply a relevant theoretic model, you can see, well, why there's a gap here? What individual, super individual, social network or structural factors contribute to all these losses? And then I just want to mention the statistical considerations. In looking at progress through this, we said we could treat them all as equally weighted steps, perhaps weight them differently. There are different statistical methods that one can apply to progress through these steps. Weighting them using something called a continuous ratio model, using GEE. It's not clear what the optimal methods are, and mostly these have not been done. There are only 1 or 2 papers that have ever applied any of this. People just show the bar graphs and go, see? So in the NIDA-CTN study, we're going to try as secondary outcomes to apply a bunch of different statistical methods and see how they work. Then there's also the question of whether the factors you're looking at are time variant or time invariant factors. We presented the steps as being sequential, although sometimes they're not. And then there's the issue of people falling out of care and being re-engaged in care. And this also relates to whether you look at cross-sectional or longitudinal care continuum models, but people can be retained in care or lost and then re-engaged, and you would like some representation of that. That's clinical work that's expended, that's cost, that's lost time, and so you'd like your model to reflect prevention, incidence, mortality, and people falling in and out and being re-engaged in care. I sort of said that. So these care continuum models are actually very useful tools. They help us focus not just on the intrinsic activity of an intervention, but its net effectiveness. There are important decisions in deciding which are the steps to look at, what the definitions of those steps should be to have the most predictive value, what the data sources should be for that. Should you look at this as cross-sectional snapshots or longitudinal? What should your outcomes be? Purely biologic outcomes, other outcomes? Do you quantitatively measure them in some way? Do you look at interactions with other conditions? And adding some of these things will make these already useful models better. And I think there are a lot of fields where these models can be applied. Again, it's sort of being done ad hoc in Hep C. There's literature in a variety of mental health fields. We have a paper under review proposing a substance use care continuum model, because that's another condition where people are not diagnosed, they're not engaged in care, they're not engaged in effective care, they relapse. So having a sense of the progress through that would be very useful. But I think there are a lot of conditions where it would be very helpful. I had a lot of fun reading this literature and thinking about this and having a lot of discussions with the folks Dan Feaster and Carlos Del Rio, part of that CTN study, Dennis Nash, who does the Care Continuums for HIV for New York State, and Ashley Jordan, who works with them, and Holly Hagan, who does the systematic reviews and meta-analyses. And I'll stop here and thank you for your time and see if you have questions. Is that?
Questions?
Well, first, thank you for your commitment to such a difficult area. And now my question is, it appears to the non-infectious disease expert, such as myself, that the city and the world are faced by two virus pandemics, potentially, Ebola and Zika. I wonder if your approaches are being thought of and applied for the Sinai, Beth Israel system, New York City, or the nation to those two single-stranded viruses.
Well, I actually haven't heard of data looking at the epidemiology or public health approach to either of them using this. For Ebola, I'm not sure it would be the most useful thing. I don't know. I mean, the diagnosis of Ebola is not subtle. We don't really have good treatments. Now, Zika would be a different issue because there are probably subclinical Zika. There would be places where we should do Zika screening. What proportions of people who might benefit from Zika screening are screened? It's a reasonable consideration that I haven't done and haven't seen. But there are a lot of conditions for which I think it hasn't been applied and could be applied. Again, for a lot of mental health conditions, it's useful for diabetes, hypertension, things for which you do want to screen people and put them in preventive systems if they're there and treatment systems. But I don't know of data for those two.
I think in the interest of time, we'll finish up there. Thank you very much,
Okay.
David. We appreciate it.